Hello everyone, welcome back to Dental Digest with the Study Boards. I'm Dr. Trehan and we have been talking about different odontogenic cysts. And in today's video, we will be focusing on paradental cysts. Let's start with the basics first. First of all, we'll talk about the origin and etiology of the paradental cyst. Then we will move into its pathogenesis. After that, we'll look into the clinical features, take a quick look at the histopathology, discuss some possible complications, some treatment options, and finally we'll wrap it up with differential diagnosis. Now let's talk about the origin and etiology of paradental cyst. This cyst is an inflammatory odontogenic cyst, which means it develops as a result of persistent inflammation around a tooth that's still vital. Very important point. Now there are two main theories about where its epithelial lining is coming from. The first is that it is coming from reduced enamel epithelium, which is left behind after the tooth erupts. The second possible source is the junctional or sulcular epithelium, which can start proliferating when the tooth pushes through the gingiva. Let's move into the pathogenesis of paradental cyst. This process usually starts with pericoronitis, that is the inflammation of gingiva happening around a partially erupted wisdom tooth. Now, when the food or debris is actually getting trapped in that tight space, it causes chronic irritation, which keeps the area inflamed and triggers those epithelial cells to start proliferating. As this continues, a small cavity forms and this lining becomes surrounded by granulation tissue. And over time, that granulation tissue matures into a cyst wall, giving rise to a classic paradental cyst, which we see clinically. Now let's go over the clinical features of paradental cyst. These cysts almost always involve a vital tooth, most often a partially erupted mandibular molar. Clinically, you will notice a buccal swelling that is happening near the affected molar. That's often the first thing that the patient is going to report to you with. And on a closer look, you will notice that a gingival inflammation has happened around that area, and the gingiva appears red, swollen, tender. And if the secondary infection actually has happened there, the patient might actually complain of pain, and you might even notice a purulent discharge from the sulcus. And when you can check with a periodontal probe, you will even find some deep pockets adjacent to the tooth that's involved, showing that the cyst actually has extended into the periodontal space. Important point for you to note. Now let's look into the two main subtypes of inflammatory odontogenic cysts that are relevant here: the buccal bifurcation cyst and the paradental cyst of mandibular third molar. The buccal bifurcation cyst almost always occurs in children between 5 and 13 years of age, so that's important. And it develops on the buccal side of first or second mandibular molars. And clinically, you will notice a tender facial swelling that can actually push those molars lingually. And in contrast, the paradental cyst of the mandibular third molar is an adult lesion. So age is important here. It forms beside the partially erupted wisdom tooth, usually along the distal surface, and it's strongly linked to recurrent pericoronitis. Now, patients often report intermittent pain and periodontal probing that shows deep pockets created by chronic food impaction and ongoing inflammation. So to make the right diagnosis, remember the differences are in age, location, and clinical presentation, and that's key for accurate identification and management of this case. Now let's go over some radiographical features of both paradental cyst and the buccal bifurcation cyst. For the paradental cyst, the classic location you're going to see on a radiograph is the distal or distobuccal aspect of the partially erupted mandibular third molar, and it usually appears as a well-defined radiolucency, sometimes even semilunar shaped, or it can even get superimposed on the roots of the involved tooth. And you might also notice a sclerotic border. Occasionally it can mimic periapical pathologies. So that's something important for you to keep in mind. And for the buccal bifurcation cyst, the typical site is going to be the buccal aspect of the roots of permanent mandibular first or second molar, and it shows up as a well-defined U-shaped radiolucency, often with a thin radiopaque line forming the lower limit, sometimes superimposing over the roots. Now, a sclerotic border may also be present, but what's important here is that the periodontal ligament space and the laminar dura of the involved tooth, it remains intact. Now let's move into the histopathology of paradental cyst. Under a microscope, it looks very similar to other inflamed odontogenic cysts. The lining is made up of keratinized, stratified, squamous epithelium, and the cyst wall is filled with chronic inflammatory cells. What are these cells? Mainly lymphocytes and plasma cells, which are reflecting ongoing irritation. And you may also notice some areas of granulation tissue containing hemosiderin-laden macrophages, which tell you that there has been some minor bleeding and repair over a period of time. And lastly, the epithelium often shows reactive proliferation. That means it thickens in response to chronic inflammation, typically triggered by recurrent pericoronitis or food impaction that's happening here. Now let's look into the complications of both the lesions. When a buccal bifurcation cyst grows larger, it causes the buccal cortical plate to bulge outwards, and that pressure can create to erode the underlying bone or even shift the adjacent molars out of their normal alignment. And on the other hand, a paradental cyst involving a mandibular third molar often blocks the eruption path, leaving the wisdom tooth impacted or misaligned. And because it frequently occurs alongside pericoronitis, it can also serve as a site for chronic low-grade infection, which leads to recurring pain, swelling, and if it's not treated promptly, it can actually cause your patient a lot of discomfort. Now let's move into the treatment, and remember, it all depends upon the type of the cyst we are dealing with. For a buccal bifurcation cyst, the management is generally going to be very conservative. The cyst lining is carefully enucleated, but the associated molar is left at its place. This preserves the tooth and the surrounding bone as well, and the healing in younger patients is usually smooth and uneventful. In contrast, when you're dealing with paradental cyst around the mandibular third molar, the treatment is typically enucleation along with the extraction of the involved wisdom tooth. And by removing the tooth, we eliminate the chronic source of inflammation, which significantly lowers the risk of recurrence here. Now let's move into the differential diagnosis, a paradental cyst and its pediatric counterpart, the buccal bifurcation cyst. And it needs to be distinguished from few other lesions that may look or present similarly. A dentigerous cyst wraps around the crown of an unerupted tooth, whereas the paradental or a buccal bifurcation cyst is often found beside erupting or erupted molars. Then we have residual cyst, that is simply the leftover of a periapical or radicular cyst, and it lacks the history of pericoronitis or active eruption. Then we have periapical cyst that occurs at the apex of a non-vital tooth, but remember, the teeth involved in our cysts are vital here. A lateral periodontal cyst then runs along the root surface of a fully erupted tooth, and it's not related to eruption inflammation. Then we have eruption cysts, on the other hand, occurring in the soft tissues before a tooth emerges, while the paradental cysts are intraosseous and appears after partial eruption. Similarly, you also have gingival cysts, which are purely soft tissue lesions, and you don't see them on radiographs. Now, an acute periodontal abscess is painful and purulent, and that can also mimic it, but it develops quickly, whereas a periodontal cyst not only becomes symptomatic when it's secondarily infected, it also takes a lot of time. So pericoronitis involves just gingival flap over a partially erupted tooth, but a periodontal cyst is a bony lesion in the same region. So make sure that you're not confusing pericoronitis and the periodontal cyst as well. And occasionally, benign tumors can also look similar. An odontogenic fibroma, it's a solid, not cystic lesion. Then we have odontogenic keratocyst, which is more aggressive, with a thin, corticated border, and an ameloblastoma that produces marked bone expansion with multilocular or soap bubble appearance, and none of which are typical with periodontal or buccal bifurcation cysts. So the key here is always going to be correlating the tooth vitality, eruption stage, radiographic appearance, and clinical history. That's what will guide you to the correct diagnosis here. Alright, now let's quickly recap the key points. Paradental cysts are inflammatory odontogenic cysts usually linked to pericoronitis around the partially erupted mandibular third molars. Chronic irritation has to be there that triggers epithelial proliferation, forming a keratinized cystic cavity. Then clinically it is painless at first with buccal swelling, tenderness or delayed eruption. Then radiographically it is well-defined radiolucency around the molar roots. Buccal cysts are expanding into the buccal plate. Paradental cysts now show a pericoronal halo. Then we talked about histology, keratinized, squamous lining, chronic inflammation, granular tissue, all of that. Treatment-wise, enucleation, you're trying to preserve the tooth in buccal cysts, and you're extracting the third molar in the paradental cysts. Make sure that you're differentiating them from dentigerous cysts, residual cysts, periapical or lateral periodontal cysts using tooth vitality and eruption status. Thank you so much for watching this episode of Dental Digest. If you learned something new today, please like the video and subscribe the channel for more videos. Feel free to share your questions or feedback in the comments below. I truly value your input. Stay consistent, stay curious, and I'll see you in the next one.